Hi, everyone. So happy to be here for another AFA Care Connection, and very excited to have with us Judith Ann Jones, DDS. She's an expert spokesperson on elder care for the American Dental Association, which is a professional organization representing approximately over 150K U.S. dentists. Dr. Jones currently serves as a past president of the American Board of Dental Public Health and as a member of the ADA's National Elder Care Advisory Board. Dr. Jones earned her DDS degree from the University of North Carolina, a Doctor of Science in Dentistry degree in Dental Public Health from Boston University, Henry M. Goldman School of Dental Medicine, and a Master's in Public Health from the University of North Carolina. And she currently is a professor at the University of Detroit Mercy. So thank you for being with us here today. We are excited. Just a few housekeeping to let everybody know that in the handout section is a PDF copy of Dr. Jones's presentation, as well as a general certificate of attendance, as well as a handout she has provided to you all for the pandemic-driven disruptions in oral health care. And in the meantime, everyone is on mute mode, but if you have questions, put them into the question section. We will get to the questions at the end of the presentation. So without further ado, I'll let Dr. Jones take it away.
Well, thank you very much, Cara. And it's really a pleasure to be here, but I can't seem to advance my slide. So I was wondering if you could do that for me or give me that control.
Yep, so you should just be able to click right on the slide, double click, and it should go forward.
Oh, I see now.
Yep, there it is.
Thank you.
Perfect.
I got it now. I'm all set. So thank you very much for that kind introduction, and it's my pleasure to join you all this afternoon or this morning, depending on where you live in the country. I'm coming from the University of Detroit Mercy School of Dentistry, where I'm a professor. I come to this topic of preserving oral health in people with Alzheimer's disease from multiple perspectives. One is that I was the team dentist for the Dementia Study Unit at the Edith Nourse Rogers Memorial Veterans Hospital in Bedford, Mass. For 20 years. In addition to that, I have 4 decades of clinical dentistry experience. And as a researcher, I've studied the relationship between oral conditions and dementia. I'm also an advocate for access to oral health care for seniors, and I'm a caregiver for a partner with a 20-year history of Parkinson's disease. My plan for today is threefold. First, I'll discuss the bidirectional relationship between dementia and oral health. Secondly, I'll go over some goals of long-term oral health care in people with dementia. And third, I'll describe ideal and minimum oral hygiene practices for patients with dementia and give you some ideas of when to refer and what to look for. But first, I'm going to tell a couple of stories. This gentleman on your left is my Uncle Harry. Uncle Harry had mild to moderate dementia late in his life. He's my godmother's husband, and often we would go on vacation with Uncle Harry, and we would often vacation on the Straits of Mackinac in Michigan. And one time we were sitting out in front of the hotel, or the motel rather, about 11 in the morning, and my godmother asked me, she said, "Judy, what can I do about Harry's halitosis?" And I said, "Jeannie, you just spent an hour and a half getting Harry showered, dressed, and gave him his breakfast." I said, "You have to brush his teeth too, because it's clear that he could no longer do it himself." Now, Grandma Shook is my sister's mother-in-law, and Grandma Shook was actually a teacher, the first teacher of color in the city of Dearborn, Michigan. And Grandma Shook developed dementia late in life. She and her husband lived at home for many years and transitioned to assisted living. And around the time of that transition, my brother-in-law John used to notice that she really had bad halitosis, and it turned out that her husband was no longer able to do her daily care, and nobody else knew that in fact Grandma Shook had a partial that needed to be taken out and brushed and stored in a cup overnight, and her teeth brushed thoroughly. When her husband was well, he would do that for her, but then when Ralph became ill, he was no longer able to do that, and so it went by the wayside. So John started to do it. Grandma Shook, after Ralph passed, transitioned to the memory care unit in her assisted living facility, and she had a new batch of caregivers who also needed to learn that she, in fact, needed to have her partial taken out and cleaned every night and her teeth brushed thoroughly every day. And John made sure that this happened by not only modeling that behavior, but also expecting the staff to do it on a daily basis. Now we know over the past 40 years, we've learned that people with dementia have more oral diseases. And I think it's in the last 40 years we've actually started to measure this. In a recent meta-analysis of 28 studies, people with dementia were found to have more decay, poorer oral hygiene, more periodontal or gum disease, and more tooth loss. In a study in the North Carolina area called the ERIC study, where they were actually studying atherosclerosis risk in communities, they also looked at oral health, and their investigators found that before dementia is even apparent, oral conditions deteriorate. Now, Chen and his colleagues actually looked at, did a meta-analysis of 8 cohort studies, and they found that tooth loss was associated with a 34% increase in developing dementia. Notice I use the word associated. It's not caused by necessarily, but it's associated. The two kind of track together. And that the increase in number of teeth lost increased the relative risk of dementia, as you can see in this slide. Now, Murray Thompson and his colleague actually proposed a model to look at the association between cognitive function and tooth loss. And what they posit is that cognitive function in childhood, in adulthood, and in old age are associated with incremental tooth loss. Now, they have the arrows going in the direction towards tooth loss, but you know, there's some people who think that incremental tooth loss is also associated with declines in cognitive function in old age, but we really don't know the answer to that. What is clear is that as you look in each successive age group, 65 to 74, 75 to 84, 85 plus, there's an increase in the proportion of people with dementia. And as you look at people with college or college degrees versus people with high school or less than high school education, you see that the people with less education are more likely to have dementia. Now, the same pattern is present with tooth loss, and these are national data that show that as you increase in age from 65 to 74 in the orange columns to 75 plus, there's an increase in the percent of the population with tooth loss. And if you, again, look at education, people who have less than a high school education are more likely to have tooth loss than people who have a high school education. or people who have greater than high school. Again, I think it's really important to emphasize we don't know which direction this association goes, or if it's bidirectional, but that association is clearly there. So that finishes us with number one. Secondly, I'm going to talk about the goals of long-term oral health care in people with dementia. And to do this, my colleagues and I, back at the Edith Norse Rogers Memorial Veterans Hospital in Bedford, actually conducted a multidisciplinary Delphi survey. The participants included the family members, nurses, physicians, neurologists, dental professionals, social work, nutrition, and therapies. And this was a Delphi survey that was completed in 3 rounds. Now, Delphi surveys are used to deal with a complex problem and to use a structured group communication in a series of rounds. This helps to minimize individual strong opinions and really harnesses the collective judgment and informed intuition of the experts, in this case, the people who cared for our patients with dementia, with the idea that the collective consensus is more likely correct. So after 3 rounds of grading different goals for long-term oral health care in people with dementia, what we found is that the most important outcomes that the group identified was that individuals be free from pain. That makes a lot of sense. Comfort is really important. Secondly, not be at risk for aspiration, either from loose teeth, from crowns that are loose, from dentures, and dental materials. I remember very clearly one year I had 3 patients almost in a row, but within a short, like 2 or 3 month period. And they all had little teeny tiny partials, some of which didn't even have clasps that hook on the teeth. And clearly they were aspiration risk for those individuals. The third goal would be that emergency treatment be available when needed. The fourth is to prevent mouth infections. The fifth is daily mouth care would be as much of a part of daily care as shaving or brushing hair. The sixth is prevent discomfort from loose teeth and sore gums. Seventh, teeth brushed thoroughly once daily. Eighth, caregiver able to provide oral hygiene care. Ninth, provide dental care to prevent problems eating. And 10, recognize oral problems early. Now there are, we generated, I think it was initially over 100 and then 78 items, but these were the top 10, and I think they're worth looking at. But if I were to boil it down to 4, I would say comfort, safety, dignity, and prevention. Comfort, we want all of our individuals with dementia to be comfortable in their later years. We want to keep them safe from anything that could cause them to aspirate or be uncomfortable for any reason. Dignity, we want good oral hygiene so that they smell clean, so that when their families come, when the grandkids come, that there's not a turnoff from the halitosis. And finally, prevention, to prevent problems from occurring. That's a really important goal as well. Well, the third thing is when to refer. And my colleague Elisa Gazy said that this was an overwhelming slide. And I think for many caregivers, when to make sure their loved one or their patient gets referred to the dentist is kind of overwhelming. And so I left it in because I think the overwhelming nature of it is really important. So really, it's important to refer people with oral lesions. This patient on my left didn't have dementia, but she had this oral lesion here, which turned out to be a secondary carcinoma, and her treatment, which caused her to lose part of her maxilla, was really quite severe. So you want to prevent and identify somebody with a lesion early on in their disease process. I think nobody in the audience would miss a cancer that's as big as this, and most of you would be able to identify this also as being abnormal, and it turned out to be a small cancer. But it doesn't look that different from this, which is normal tissue underneath the tongue, which is why I showed this one. And this doesn't look that different from this little precancerous lesion in the same area. None of you are going to miss this large cancer or this really extreme poor hygiene and dental caries. But you might miss an ulceration like this, which when healed looks a lot better, but still doesn't look that great. Excuse me. Hopefully, all of you would find a lesion like this on the side of the tongue or this on the side of the cheek. But anytime you see an elder with an oral lesion, that's certainly cause for referral. You should also refer elders with ill-fitting dentures. And actually, these dentures in the upper left are not ill-fitting, but they were associated with this woman with this severe rheumatoid arthritis. I call these my combination dentures because usually people put in the top first and then the bottom, but with her, especially with this level of arthritis, she had to put in the bottom one first and then the top one. There are many people like this gentleman who have severe deficit in their mandible, which has resorbed when the teeth were lost. But when you see his dentures in, you know, they actually look quite good. This is one of my ALS patients who needed help with his upper denture and lower partial. And this was one of my favorite veterans. He was a World War I veteran who was exposed to mustard gas. And I made him dentures. And I put him there because he was such a great guy, but I also put this next to him because that's how clean you want the dentures to look when you take them out of their mouth every night. It's also important to refer elders with tooth decay and gum disease, and I think that kind of goes without saying. And I think most of you, if you look in somebody's mouth, you can find or you can identify people with broken teeth, missing crowns, tooth decay, and severe problems with oral hygiene, and even this redness around the gum line. I did have one patient in the dementia study unit who I used to see every 4 months. And one time I came to see him, and after seeing him, I asked his nurse if they had stopped the nifedipine, which is a calcium channel blocker. And her eyes got so big because she just couldn't believe that I could see the difference, but the difference was really apparent. So there are some medicines, namely including calcium channel blockers and phenytoin, that really wreak havoc with the periodontal or gum tissues. And so it's really important in those individuals to have even a higher level of care. This is the same set of slides. The poor oral hygiene warrants referral also. And I think anytime you look in somebody's mouth, if they just have received a diagnosis or they're in your care, and you're looking in their mouth, anybody with really poor oral hygiene would need referral. So to summarize, conditions that warrant referral include pain and discomfort and swelling in the mouth, anybody with red or white or mixed lesions in the mouth, and as you look in people's mouths, you get a sense of what's normal and what's not normal. Anybody with obvious tooth decay, bleeding gums, recession of the gum with bleeding, anybody with pus in their mouth. You want to find out what's the source of that infection and eliminate that source. And then anybody with dentures that are either ill-fitting or move on function or no longer fit or dirty, these people would need to be referred. Now, honestly, all dentures move on function, but the motion should be very small. So if you're sitting across the table, you're socially distanced, and you're eating, and the person across the table is eating, and their dentures are flopping up and down, that's moving on function. But every denture does move a little bit, and that's normal. And then anybody with a foul odor should actually be referred as well, because you want to know what the source of that foul odor was. It doesn't mean you're always going to treat the source. We had one fellow with, he was on the dementia study unit. He had impacted wisdom teeth that were causing a periodontal problem or a gum problem behind his second molar teeth. And so we found those teeth on the initial exam, and we brought them to the attention of both the nursing staff as well as the family, and we talked with them about what should be done, because typically the treatment should be, extraction of those teeth. But he was in a position where the family really didn't want to have him undergo any additional treatment. And so we just monitored him and made sure that it didn't get any worse, that it didn't bother him. I did have a fellow with dentures where his lower denture no longer fit, and that was because his lower denture, the bone underneath it was expanding because he had a large lesion in his mandible. And even though he was 82 and had dementia, because it was affecting how he ate, we actually sent him into Boston, and he did have that cyst removed in his mandible, and we actually relined his denture and had it wired to his jaws for a while, so that his jaw, which was so fragile after the surgery, needed to be splinted, if you will. And then he did very well afterwards. So, it's each individual. You have to make decisions based on what the situation is. The bottom line for me is that good daily oral hygiene is critical. Somebody has to do it, and it really should be done daily. My friend Elisa Gezi says if you don't take care of yourself, your oral hygiene falls apart and you lose teeth. And that's important because you need those teeth to eat for good nutrition. She suggests that if we want to make an impact on the oral health of people with dementia, we need to equip caregivers to provide care. Dentistry can oversee this, but the day-to-day is where the priority and funds need to be. The day-to-day needs educated, equipped, and motivated caregivers, and I couldn't agree with her more, or else I wouldn't be showing this to you. She also suggests that access to hygienists every 3 months or 4 months is critical if you want to keep your teeth and can no longer care for them on your own. People are not planning for an increase oral health care needs and costs, as they get older. They need to start hearing about it in their 40s, she suggests, and that no one is going to hand oral health care to you like other medical conditions are diagnosed and handled. She goes on to say, unless an individual and caregiver decide to make it a priority and seek care, it won't happen. She said, I don't think our society gets this. They think growing old is a package they sign up for, and the healthcare team addresses all their issues. Oral health didn't get put into that program. We need to consider that maybe it should, but right now, it isn't dentistry that's going to make that happen. It's really the family and society that has to make it happen. And finally, I'm going to talk about ideal and minimal oral hygiene practices. Clearly, for people with teeth, they need regular checkups and fluoride treatments. If they have teeth, that should be 2 to 4 times a year, depending on the individual and their level of oral hygiene. If they don't have teeth, they need to be seen at least once a year. Ideal daily care includes brushing for 2 minutes twice a day. It takes about 2 minutes to go around the horn and do a really good job in every little specific place. And then either floss or clean in between the teeth. I like these little cheap floss holders, unless I see them on the ground outside because people are too lazy to throw them in the trash. But they are really good for people who can't do it otherwise. These little brushes to brush in between people's teeth are also very good. And in fact, I use these on my husband quite a bit in his later days. And then daily fluoride paste or gel or rinse, I think that's something that's really important as well. At a minimum, daily brushing should be for 2 minutes with fluoride every day. The flossing, if you could do that 5 days a week, or the cleaning in between the teeth 5 days a week, that would be awesome. I remember one gentleman, his jaw would open lock, and so we had to put him into a fixation with rubber bands, and the nursing staff would open and close his mouth and clean his teeth on a Monday, Wednesday, and Friday schedule. So they take off the rubber bands and brush the teeth really well with chlorhexidine liquid, and then wipe everything down really well, and then put the rubber bands back on to keep the jaws together so that he wouldn't open his mouth and lock open, which is very painful. Common questions I get. How can a caregiver communicate with a dentist about the individual's diagnosis? I would say over the phone when the appointment is made, and also when completing an online or paper health history would be another opportunity to do that. What can be done for the oral health if the individual is reluctant to go to the dentist's office? I think it's important to be proactive and maintain regular attendance, even after the diagnosis of dementia, and before somebody gets to long-term care, if that's the case. The reason I say that is because, if somebody's used to going to the dentist, they sit down in the chair and it's just normal for them. So I had many patients who, as soon as they sit in the dental chair and you lean them back, they open their mouths. I mean, it's just part of what they're used to doing. So I think being proactive and maintaining regular attendance when you can is something that's really good. Teledentistry can introduce an individual to a provider who then can encourage the individual to come into care as well. So many of you may have questions as well, and so Kara's going to go ahead and read those to me, and I'll be happy to answer them.
Yeah, definitely. We do have some questions coming in, so we'll go at them one at a time as people put them in. So we have one person who asked us, is it necessary for someone with Alzheimer's to get mercury removal from teeth?
And the answer is unequivocally no. And my reason for that is there was a great study that was done in Kentucky, now probably 20 years ago, by Stan Sachs and Robert Henry and their colleagues. And they actually did a study in nuns, and they found that the amount of silver amalgam, which is a mix of silver and mercury and other metals that makes up the silver fillings that are in people's mouths, was unrelated to the severity of cognitive change. So I think unequivocally no. You know, you don't want to be messing around with people when you don't need to. So I would disagree with that.
Yeah. And we always want to think about, especially for persons in their end of life stages, you know, what's going to be worth it or not. So at that point.
Right.
Yeah. We do have another person with us who's asked a question. I think this is something that's definitely come up just with the context of the time we're in, but her question is, what do you do when a nursing facility doesn't keep the residents' dental care properly, but they're not letting you in either?
Yeah, so there was a really great series of webinars by the Gerontological Association of America, and actually the handout, that one of the handouts that you have addresses this. But I would say that good daily oral hygiene care is just as important as, you know, brushing somebody's hair, giving them a bath. If, you know, under COVID, it needs to be cut back a little bit, that would be fine. But once somebody is gowned up to do all the bathing and grooming and dressing, that's an ideal time to do the oral hygiene care as well. And I know it's difficult, but I'll be honest with you, in treating patients over 20 years in a dementia study unit, I found that less than 5% was unable to actually do an exam and brush their teeth and that kind of thing. And one of the things I always did, and the hygienist would do this as well, is if nursing staff or CNAs were having difficulty with an individual, I would ask them to tell me about it, and we would actually go bedside, and I would do half, and then they would do half of the mouth, so that they would clearly understand, you know, what the best approach was for this individual, and it really is individualized.
Yeah, and it's whatever works for that person.
Right.
Definitely. I do have someone else who's now asked, do you have suggestions for individuals who might be awake grinding? It seems this individual that the mouth guards aren't working because they take it out or chew it, but what are other alternatives if they're awake and they're grinding their teeth?
Right. So I think one option is for them to chew xylitol gum. That's a possibility. Of course, you don't want the gum on the floor or on the bed or in their hair. So, you know, you have to weigh it. But, you know, one of the individuals that I was most not able to approach and care for, he was grinding his teeth all the time. And I think in somebody like that, chewing gum might be an alternative. And it might not, but it'd be worth a shot. You know, but I would not use a sugar gum. I would use a xylitol gum, because xylitol is a sugar alcohol that substitutes for sugar, and the bacteria that live on the teeth are not able to metabolize the sugar alcohol, the xylitol. So, that's a good choice.
Mhm. Mhm. Yeah, and again, it's seen what works. Your person might also maybe be grinding their teeth because of boredom or other things, behaviors. So you just want to see what also other things come up and consult with their dentist.
Right. Right. And
Yeah,
if you can do an exam, and see if there's something that's bothering them. Yeah.
Mhm. And if it's something where you're unsure of, you can always, because I think do this right. Some facilities do have someone who might be on staff who can come in and check it out. So sometimes it's better to check in with the staff that's there if you're unsure of who to go to in the facility if you're a caregiver. But that can always be a first step in communicating.
Right.
Yeah. So we do have someone else. I'm probably going to pronounce this wrong, and Judith, I'm so sorry. But I'm going to try and say it. But it says, what are your thoughts on axolotl mouth rinse? I think I said that right.
What's it called?
It's axolotl. So it's XYLITOL mouth rinse.
So that sounds like act and xylitol. And
yes,
if it is
that's
act
probably
and xylitol, then that would be really good. Act is a fluoride rinse that many people use, and it actually prevents decay on the order of the on the order of the fluoride treatment that is provided in the dentist's office. However, you want to make sure that somebody's not going to swallow the mouth rinse. So that's where you might have an issue. What might be better than that is a fluoride varnish that can be applied to the teeth with a little tiny brush. So you dry the teeth off, and then with cotton, and you isolate them and paint them with the fluoride, and that works really well. The fluoride rinse, if somebody can rinse and spit, that's great. But if they can't, then that's something you just have to evaluate it, and that would be individualized. And it may change over time. So somebody might be able to rinse and spit for 2 years and then no longer, and that's when you would switch over.
Yeah, we definitely want to always reevaluate what our person is having trouble with or not with their ADLs as they are progressing through the disease, because like Judith said, one day they might be able to handle all those routines, and then another day there can be some struggles. So you just want to see where your person is along. And we do have someone who has a question, Judith, who asked, is it recommended that if you have a person in the early stage of dementia, can they go under a tooth implantation if needed?
So, if it's a front tooth and you want them to look well, then it might be reasonable. I remember one of my fellows went on to practice in the Southwest, and he was at a nursing home, and the staff and the patient kept losing the dentures, and so they placed 2 lower implants, and they would attach to the denture, and so the dentures were no longer lost. Again, you have to evaluate on a case-by-case basis. I remember one of my patients, not with dementia, but who had been homeless. He had an implant in his one of his front teeth, but it wasn't restored, so it didn't have a crown on it. And when the resident restored it with a crown, he said, Dr. Jones, you changed my life. And so if it's going to be life-changing for somebody, even with dementia, because they're going to look nice, and people are going to respond to them better, then it might be worth it. But you have to, if it's a back tooth or a side tooth, it may not be worth it. You know, if I had dementia, I know I have an implant because I cracked a tooth and it couldn't be saved. And so I had an implant placed. And it made me really self-conscious to smile, but most people wouldn't have noticed it, quite honestly. But but so if I had dementia and I was even in the early stages of dementia, it would probably not be a good idea because it would make it harder to clean and everything. You have to be more fastidious in your oral hygiene. But, you know, and people who are taking care of me might not spend as much time or effort on it as I do personally myself now because I'm a nit, you know. But, you know, again, it's a case by case basis.
Exactly. So you just want to talk to the people that are involved with that person's care and evaluate and see. And thanks for sharing that with everyone because it is very relatable. And you want to think about, you know, if you were in a similar position in those shoes, what is something that might come up for you if you ever got to that point, and what would your needs be?
Right. So if it were one of my front teeth, I would want it.
Yeah. And she did reply back. She said, yes, it's a front tooth.
Right. So
we do have someone who asked, you know, have you found anything in literature that correlates with chronic oral inflammation and dementia?
So there's some work in the periodontal literature that suggests that the bacteria that are in periodontal disease are also found in plaques and tangles. So, you know, there is an association there. Now, is it causal or is it incidental? We don't know, quite honestly. We don't. And I think it's, you know, something that we have to keep looking at in different ways to see if there's an association or causality. But causality is a very tough thing to determine because there are probably 6 or 8 criteria that you have to satisfy to say that something's a causal relationship. You know, you have to have a dose-response relationship, and you have to have the exposure before the disease, and you have to have a moderate or strong correlation between them. And, you know, there's a variety of other things that need to be present before you say A causes B. But clearly, you know, tooth loss, clearly poor oral hygiene and dementia go, you know, they march along together, but whether that's just an association or there's any causality, or like diabetes and gum disease, whether it's a two-way street, we don't know yet.
You have to kind of see what happens.
Yes.
We do have someone else who's asked, is there any specific type of toothpaste that you might recommend for someone just because they seem to have an issue with just spitting it out? It could be someone with digestive issues. So she heard that children's toothpaste, is that something that would be recommended?
So I would just put
hard question.
I would just put a little tiny bit of fluoride toothpaste. I'm a strong believer in fluoride toothpaste, and if it's a stronger fluoride toothpaste, that's probably better. If it's anti-gum disease, that's probably better. But I would only use a little teeny tiny amount. Now, so a lot of people like to put a whole bunch of toothpaste on all the bristles of the teeth. I think in terms of 2 tiny drops. And that's all you need to brush your teeth. And so then you have less of the toothpaste all over everything else.
And we do have someone who asked us if you could actually go back and repeat the protocol you had talked about for the dental visit for those that have dentures.
Oh, the protocol. So I think if somebody has dentures, they should be seen at least once a year. Okay, if the dentures are dirty, or ill-fitting, they need to be seen more often. So, you know, it really is individualized, but I think everybody needs an examination once a year. You know, just a brief examination, even if they have dentures and don't have any of their own natural teeth. And that's where we discovered that this denture really wouldn't fit, and this guy had the swelling of his mandible. I mean, it was pretty remarkable, and it was somebody that I had seen multiple times before, and then in just a period of 6 months or a year, his mandible expanded dramatically, and the dentures no longer fit, and you know, he had real problems. He had this big cyst growing in the middle of his jawbone, and you know, you can have those anywhere. So that's the kind of thing that really it doesn't take a long time. You know, it's like a 10-minute visit. And really, the exam takes about 2 minutes, and the conversation takes about 8.
Okay, so that's good to know. And we also now have someone who says, have you heard of a sedation dentist? She's been recommended to consult with one. And is it normal to speak with someone? And are there medications to avoid if they do see one?
So sedation dentistry is, I think, appropriate in a small percentage of individuals.
Okay.
And so, you know, I mean, for some people, they might just be having a bad day, and I would see them again and not have any problem. But in people who were, you know, just didn't do well in the chair, I would ask. These were typically people who didn't do well at other times also. And so whatever medicine worked well for them in the long-term care setting or at home when they were anxious or upset, I would ask the nurses to give them that medicine before the treatment. But I never did IV sedation. I really didn't find it necessary in my patients. And I felt like, you know, 95% of the time I could get the job done without any kind of pharmacologic management.
Okay. But if someone did have to, because they have a follow-up question, if they did have to work with sedation, are there any questions that they should be asking when they do bring the person to the appointment?
Yeah, what kind of safety procedures do you have in place?
Safety procedures.
Yeah, you know, how often do you do this? If they do it every day or one day a week, all day, then, you know, that's somebody I would go to. I would take my brother to, or my, you know, family member to. But if it's somebody who's doing it just once a year, no.
What is, now we have an additional question. How does flossing work best for individuals with dementia if they don't like things going in their mouth? Is there like a way that we could approach them or talk to them, you know, trying to get them to start the flossing? Does that make sense?
Yeah, so flossing is difficult. There's no question about it. And so, you know, those little floss aids are really good. You know, at some times my husband wouldn't even open his mouth, but I would just clean in between its teeth with those little brushes. And I wouldn't force him, you know, in the spaces that are too tight where it wouldn't go in. I would just not go in. But it really does do a nice job cleaning the spaces that are accessible. And I think whatever you can do is better than nothing. And, you know, I think there are some really good references at the back of that GSA document that show they have pictures and videos, links to pictures and videos that are really, really good. So I would recommend that people use that material and look at it to see. I think the most important thing is getting the teeth brushed once a day really well. And if you can get in between the teeth and clean, that would be really helpful as well. I think that'll help to prevent disease and halitosis and problems. And that's what you want to do. You want to prevent any additional problems because it's difficult enough.
Yeah, and we want to do anything that we can that would be preventative so that way no issues would come up later.
Yep.
We have someone, I'm going to try and pronounce this, Judith, and I'm sorry for my lack of knowledge in this area, but I have someone who asked, how about silver diamine fluoride? Does this work with decay in dementia?
Yeah, that's a great question. That must be a dentist. Okay. Yeah, so silver diamine fluoride, we call it the silver bullet. It's like the best thing since sliced bread because what it does is it actually arrests the decay. It stops it in its tracks and makes the tooth hard underneath the leathery decay that's there. And that's great because there are many people that it's inappropriate actually to drill and fill their teeth anymore. So silver diamine fluoride is really great if you can, brush the teeth really well and then dry them nicely and paint this stuff on. The only problem is it turns the tooth black. So it turns the decay black. So you don't want it on your front teeth right up in front if that's going to bother you or bother the family member. But if it's down below here or on the inside or in the back, it's great. It's fabulous. And to just arrest the decay and then go back in front and fill those ones in front that show with some either a glass ionomer filling or a glass ionomer composite blend. Those are the white fillings. That's, I think, a great service that people can do. But silver diamine fluoride, a couple of times a year, you can't beat it.
Now, is that something they would need to see a dentist for, or is that something like...
Yes.
Oh, okay.
Yes.
So you guys would have to go in person.
Yes. I'm in our hygienist. It can burn the tissues. So, it's pretty caustic. It's 38% silver diamine fluoride. It's pretty caustic, but it works really well. So, you have to, clean the teeth, dry the mucosa in the teeth, and then keep the tooth dry and paint it on with a little teeny tiny brush right where the decay is, and it works great.
Now, we do have another question. Oh, sorry. Go ahead, Judith.
I was just going to say, another alternative to that is fluoride varnish. Now, that's not as strong. It's like half as strong as silver diamine fluoride. So, there's less of the black and more of the brown turning brown. But that works well, too. So that's another option. But the drawback on that is you can't eat for at least an hour. People say 4 hours.
At least an hour?
Yeah.
Okay.
Afterwards.
With the silver one you mentioned, can that one you usually eat right away afterwards or no?
I would wait a little while, but not as long as varnish, because varnish is it's like varnish. It's you paint it on and it stays on the tooth. And what it does is it creates calcium fluoride reservoirs, and then the fluoride leaks out over time and combines with the tooth structure and remineralizes the tooth structure. So it's they're super good. It works really well, but you have to just choose which one depending. If somebody's really opposed to the tooth, the decayed part of the tooth turning black, which is already orange at least, then you need to go with something that's a little bit, causes a little bit less color change.
Yeah, and this also is helpful because if you guys can bring these options, to your dentist, you can let them know, I heard about this or this. Which alternative do you think works best in this situation? Just as Dr. Jones said, it's a case-by-case situation and what's going to work better for that person. I do have another question. I've actually had this question come up on the helpline a lot as well. because of a lot of heavy marketing on the at-home water picks, what are those things you would recommend that a caregiver could use with their person in helping them with cleaning their teeth?
Yeah, and if the water pick that's combined with the toothbrush, I would say that's a good option. But again, if you're pushing a lot of water in somebody's mouth, you have to be able to make sure that they're able to spit or swallow. And, yeah, some people can do that and some people can't. So, I mean, while you're doing it. So, but a manual toothbrush is good, but in a lot of people, an electronic brush is better. It's easier to hold. It moves for you. You just aim it along the gum line, and it just zips everything up. And if it's got the little water pick feature in it, that's great. But if it doesn't, just an electronic brush is actually a good option as well.
And so that's also something to look into. And, obviously this comes up a lot with swallowing issues. If we notice the person's having issue with swallowing, we do want to make sure to see if there's any oral pain they're experiencing. But also that might be a case where if you're consulting with your dentist, you might have to consult with a speech pathologist to check on how their swallowing is, as Dr. Jones says.
Yeah, you don't want them choking on the excess fluids,
Yeah.
If they're used to just sipping a little bit, or thick liquids, then that thin liquid in the water might not work.
Absolutely. And we just want to make sure we're doing the best care. Now, everything we're talking about is also, if your person is in a facility, you want to consult with the care team and the people that are there in person about this. Just as Dr. Jones said, they need to know the oral history care of this person. So if they have the dentures or implants or partials that she mentioned, this is something where you need to communicate with them about it so they understand that the need for that routine for this person.
Right.
Yeah. We do have someone else. We're getting so many questions, and I just want to say thank you so much, Dr. Jones, because we're just getting so many rolling in and getting a lot of thank yous for going over this stuff and taking the time to. So we have someone who's asked about, is there a suggestion for someone to follow a normal routine? Is there a typical time of day that might work best because they've always brushed their teeth during a certain time, but now the routine might be shifted because of the dementia?
So figure out what works best for your individual. I floss while I'm watching TV at night and then brush before I go to bed and after I eat breakfast. But, everybody's got a different routine. And so you got to figure out what's best. If you're a caregiver in a long-term care facility or assisted living, your client may not do best with toothbrushing after breakfast, but may do a lot better in the afternoon. Just figure out what works best for them. Try different times of the day for that. If you're going for that once a day, try that time that works the best. It's like getting the dentures out and cleaning them. A lot of people won't give up their denture at night, but so slip it out when they're taking a nap and clean it up real good and store it in a cup of water then. Figure out what works best for them.
Yeah. And routine changes over time, so you just want to just double check on that.
Yes.
And we do have someone who said, if a person has dementia, and I actually think I want to add to this question, because sometimes I find individuals actually hold food in their teeth. Is it best to brush their teeth after breakfast and general meals if that's something they're doing?
That's a good question and a good thing. People would squirrel their food in the pouch between their teeth and their cheek. And that would happen after meals. So sometime during the day after a meal is a good time to do the oral hygiene care. But again, you have to think about, when do they have the most food? When do they have the most food in that little cheek? And approach it that way. If you can choose the time when it would do the most good and it's well tolerated, then that's the time. And again, it's individualized.
Yeah. And so I'm looking at our time, and I just want to say thank you to Dr. Jones for being with us today, going over this information. It's so great to have someone in this field to talk about this. And I'm even getting comments saying, thank you so much. This isn't talked about enough, and it's just so very important to be discussing, especially among pre-COVID and post-COVID, to be discussing this.
Right.
Someone else just said, excellent information. Thank you so much. I completely agree. It's very important to be touching on this. And just as Dr. Jones says, if things are coming up for your person, consult with the care team that's there. If you do find that, right, the care team, if that person is in a memory care, is not being as communicative, this might be a position where you have to seek advocacy with a long-term care ombudsman. That is something we can assist you with on the helpline. But I'm just getting so many people coming in, Dr. Jones, saying thank you for providing this information. They're a very strong advocate for good oral health care. Fantastic. We need much more awareness on this medical insurance and political views of this care. So I absolutely 100% agree. I thank you for taking your time with us today. And as mentioned, her handouts are in the handout section on the side. I can also email those out if any of you are having issues downloading them. But thank you again so much for being with us today.
It's my pleasure. Thank you very much for the opportunity to speak with everybody and to answer at least some of your questions.
Yes, we had a lot of great questions coming in. If things come up, please feel free to reach out to either of us and we can assist further. So thank you again, and I appreciate you being here with us today. Take care.
Thank you.